A 29-week premature neonate presents with progressive expiratory grunting and retraction shortly after birth. I'm showing you a series of chest radiographs from this infant. Describe the findings on the initial film.
Okay, assessing the provided imaging. The initial chest radiograph demonstrates very low lung volumes and diffuse, symmetric, fine reticulogranular opacities throughout both lungs. Prominent air bronchograms are seen extending out to the lung periphery. A nasogastric tube is positioned in the stomach, and an umbilical artery catheter is noted, showing the characteristic U-bend in the pelvis before ascending to its tip at the level of the fourth lumbar vertebral body, which is a satisfactory low position. No pneumothorax is seen. These findings in a premature infant are typical of hyaline membrane disease.
Describe the pathophysiology of hyaline membrane disease and how it is treated.
Hyaline membrane disease, or respiratory distress syndrome, is caused by a deficiency of pulmonary surfactant, which is synthesized by type 2 alveolar cells and normally begins around 24 to 28 weeks of gestation. Without surfactant, alveolar surface tension increases, leading to progressive alveolar collapse, diffuse microatelectasis, ventilation perfusion mismatch, and severe hypoxia. Treatment involves administration of exogenous intratracheal surfactant and positive pressure mechanical ventilation or continuous positive airway pressure to recruit and stabilize the collapsed alveoli.
What are the classic radiological features and complications of positive pressure ventilation illustrated on the subsequent radiographs?
Positive pressure ventilation can cause alveolar rupture, leading to air dissecting into the lung interstitium and bronchovascular sheaths. This is known as pulmonary interstitial emphysema, visible on the third radiograph as fine, bubbly, or linear branching lucencies extending to the lung periphery. This interstitial air can compress pulmonary veins, causing rapid clinical deterioration. It can also rupture into the pleural space or mediastinum. The second and third films illustrate a large left-sided tension pneumothorax, demonstrating a hyperlucent hemothorax with collapse of the left lung and mass effect causing deviation of the mediastinum and trachea to the contralateral right side.
Contrast the clinical and radiographic features of hyaline membrane disease with transient tachypnea of the newborn, neonatal pneumonia, and meconium aspiration.
In that case, transient tachypnea of the newborn occurs in term or near-term infants, often after cesarean section, and is caused by delayed clearance of fetal lung fluid. It shows normal or increased lung volumes, prominent vascular markings, fluid in the fissures, and resolves within 48 hours. Neonatal pneumonia can appear identical to hyaline membrane disease with reticulogranular patterns and air bronchograms, but typically features normal or hyperinflated lung volumes and asymmetric consolidation. Meconium aspiration occurs in term or post-term babies, presenting with hyperinflated lungs and coarse, patchy, asymmetric consolidation, and lacks peripheral air bronchograms.
How would you manage this patient as a radiologist?
Well, as a radiologist, I would recommend comparing these radiographs with prior films to evaluate the progression of the reticulogranular pattern and detect early complications of positive pressure ventilation. I would suggest checking the placement of all tubes and catheters on every film, ensuring the umbilical vein catheter tip lies at the junction of the inferior vena cava and right atrium. I would recommend immediate clinical intervention, specifically needle decompression or chest tube placement for the left tension pneumothorax. Finally, I would document the findings, evaluate for signs of pulmonary interstitial emphysema, and communicate the urgent findings directly to the neonatal intensive care team.